Yes or no?
जी सर, आ रही है आवाज।
Thank you. Yeah, guys, I was told about this thing yesterday afternoon. Okay, so I've just hashed up whatever I could. So what we're going to talk about briefly is CTG. Then we're going to discuss, first of all, probably today we'll go on the physiological significance of whatever is going on. And I don't want you to remember everything, but I do want you to bear in mind what actually is going on so that you have a rough idea that when there is a CTG derangement, what you need to do. And that process, you don't have to complicate it too much in your head. And there is no, rocket science involved. As a doctor, when a lady presents to you in labor, you have only a couple of things to do, really. Most important is monitoring. And as far as her labor is concerned, what is the weapon that you have? The only weapon at your disposal, as far as the pharmaceutical sort of an intervention that you can do, medication that you can give her. It's not a pharmaceutical intervention. लेकिन चलो, okay, I'll agree. चलो जी, we probably have two weapons then. What can you give her, or what do you give her routinely? And I'm not asking you something which is, I don't know more than you anyway. All I can do is I can assimilate things better for you. Uh, It's syntocinon. Okay? That's the only thing you have. Either you turn it on, or you turn it off, or you stay away from it. That's your decision. That's the decision based on your monitoring. The the thing about so that's all that you have really. As far as her labor is concerned, that's all you can give her. There are a couple of new and latest and advanced things that you can give her. So I can briefly discuss it, but if I had gotten a better opportunity or more of time, I, or if I get another chance, I can go into what you need to do when something goes wrong. I hope we have time today. 9:25. Let me know what Dr. Rashid is going to tell. See? All right. Uh, CTG. What do you understand by labor? Hmm.
The regular kind of contraction,
Hmm.
which is about the basic interrogation of the cervix,
Avash.
leading to the delivery of the baby and the cervix.
Great. Okay. Descend to the head first and then
Yes.
hopefully deliver.
Presenting part.
Presenting. Well done. Okay. So what do you think is happening at that time while the baby, woman is having regular uterine contractions? क्या होता है? Whenever she contracts.
Contraction, there's approximation to the baby.
क्यों? Muscle
So
contract. Why does it hypoxia to me? Muscle is contracting. No hypoxia here.
because blood supply is compromised.
कौन सी blood supply होती है? Intervillous होती है ना, उसकी जो blood supply होती है वो with every contraction वो थोड़ी देर के लिए transient. Why am I? If I speak in Urdu, stop me. ठीक है? Because it's not going to be of any benefit to you. Basically, this is in a nutshell. The regular contraction leading to reduction in blood flow, transient, I add transient temporarily, reduction in fetal blood oxygenation. Inadequate oxygenation will obviously require. So what you're getting on a CTG is the cardiotocograph of the baby's heart. What's the heartbeat like? Okay. So first you need to understand exactly what is going on, what is normal, and then obviously everybody's been to the labor ward, and then you can actually judge what the hell is going on, even if you don't understand it, that's how you cheat. Okay? Even if you don't really understand what's going on, if you have just use your if you just use your common sense and you just try to understand or put your hand on the baby's tummy and feel the contraction and see what's going on, then the interventions that you can do are very limited, particularly in modern day medicine. when we used to do a CTG, and if the CTG wasn't correct, just a few years ago, 4 or 5 years ago, 6 years ago, we always had to do, I'm talking about Bart, his fetal blood sample. Okay? Scalp, you make and take blood, do a pH of that blood. And remember, there's uh, one number, 7.2. Okay? If it's less than 7.2 or 7.2, that means the baby is 7.2 pH is acidemia, acidotic. That means do something, deliver the baby, get something out of it. And if it's between, there's this range where it's more than 7.2, but it's less than a certain amount, then you need to repeat it in half an hour and see where things are going if you don't deliver the baby by then. That thing is a thing of the past now in a lot of centers. So what you need to do now is very simple, and you can do it over here also. So we'll come to that later. Anyway, is there any benefit of this thing? So evidence suggests that if you monitor the baby's heart, obviously it doesn't take Einstein to figure it out that there is a reduction in intrapartum death. However, and it's important, however, even if you have the CTG on all the time, it goes up and down like in labor, and you're reasonably okay with it. And there's a little mild degree of what you feel is she's getting lakes, as we call it. You still deliver the baby. There is still no guarantee that the baby won't have any neurological deficits, because the neurological deficits won't be covered by the baby's heart rate. So, in a nutshell, basically, the neurological deficits that babies have, uh, it's not really, there's not really any difference. The other thing which we can think is whether you want to do it all the time, as we do it, or we do it intermittently. Obviously, they've done all the research is mostly Indian and our Western allies. Organizations endorse intermittent. Either you can do a Doppler and do the check the dug of the baby in low risk, or the other thing you can do is fetoscope. Have you guys used the fetoscope? Outdoor? Do you know how it works? Good. Fair enough. How rarely is this case in real life, and until and unless you are stuck in an environment where you don't have access to CTG, you will always use it. It's more comfortable, time consuming, and better for your back. Okay. Obviously, the consensus in high risk pregnancy is to continuous monitoring. Physiological significance. Okay, what we'll do is we'll do all these things one by one. I was asking Anisha this thing before we started. What are the 4 or 5 things? And obviously, I hope everybody knows. You start off, whenever you see a CTG paper in front of you, what is the first thing that you should do before, or 3 or 4 things that you should do before you even start to comment on the CTG? Common sense. I'm not asking you any rocket science here. Still straightforward, simple. You hand me a piece of paper, and you say you bed number or cabin number, Lana. This patient is I don't like the CTG, or I just asked for it in the morning. I said, Acha, show me the CTG, morning CTG of that patient. Shabash. Anything you're missing? Can you guys hear me? Are you awake? I think they're all dead. Okay, all right.
सर बहुत क्लियर आवाज नहीं आ रही, थोड़ा सा आप माइक को अपने सामने कर लें।
अच्छा जी, अब ठीक है जी?
आप ठीक है सर।
Okay, thank you. All right. What is the other thing that you can think of? This is
condition of the mother as well.
हाँ बोलो ठीक है.
She's having any fever or any
हाँ
cardiac or
शाबाश.
any drug effect.
Okay. Her name,
The name,
her age, her parity. ठीक है, थोड़ा सा हाँ time when this was done. ठीक है, this is 15 minutes ago, this is yesterday, this is last night CTG, this is this morning CTG. Time. ठीक है? And one more important thing that you mentioned fever, you mentioned blood pressure. I'd always like to know the blood pressure, temperature is okay, she's afebrile. Why I'm saying that, you, I'm just building you up for it so that you start understanding why it's important. What else? There's one more thing you're missing. She's having pains. So where is the pressure transducer? Okay? So you need to check for that, because otherwise your CTG, your all the pathological conditions that can possibly happen, you will miss them because it makes no sense. Okay? What's the difference between well, hello, we will come to that. Okay? So name, hopefully parity, hopefully age, particularly immediately hospital. There's a 40-year-old primary gravida after having IVF, okay, has had 4 or 5 miscarriages in the past. This is probably her last chance, best chance to have a baby. She's 9 months pregnant. She starts contracting. It's a completely different ballgame, even though in an exam situation, it's not. Because every baby is supposed to be taken as the same. But some babies are more equal than others, as because this is Pakistan. So so it's very important. The other thing, her temperature, her blood pressure. Then you go to your CTG things because वो ऊपर होता है, and then what lies below is extremely important, is that your transducer. And what you should focus on is the fact that and if there's this is whenever you enter the labor room, you are first time in labor ward, I'd never even seen a delivery. But once, and then there is staff, there are nurses, midwives available who tie these things up. Okay. And then when you go abroad, then you realize that you are supposed to do this yourself, which could be extremely embarrassing. And the patient loses a little bit of confidence in the doctor who doesn't know how to put on this thing. Okay. So she also looks at you and says, yeah, that's so I think you'd start doing it yourself, and particularly when you're doing the transducer, don't trust anybody else with it. It's usually on the fundus, just a little bit below the umbilical or umbilicus, or just a little bit above it, depending on how big or small the girl is. But it should reflect it, and you should stand there for 10 minutes and make sure that you know it's actually picking up the contraction. Otherwise, when you show me CTG and there is no pressure thing attached to it, I'm sorry, you can hardly comment on this. So the baseline, which everybody I'm sure knows, 110 to 160. What does it reflect? That's the first thing I said, because uh, they've divided the CTGs into 3 parts these days. CTG in the category 1, category 2, category 3. Category 1 is the first class one. Category 3 is the absolute rubbish one. Category 2 is somewhere in between. Okay? So 110 to, it reflects lack of pathology, that there is no cardiac problems, humoral problems, immoral problems actually. Medications. What medications would you think would cause the baseline to drop? You feel free to join in, you guys, if you are awake. Huh? Huh? लिखा हुआ. Syntocinon, what will syntocinon do? Doesn't really affect the baby's heart, does it? Or maybe if it does so indirectly. The only side effect of syntocinon or excessive syntocinon is probably a bit of water intoxication. But other than that, it can cause, yes? Hyperstimulation. That's a, it's possible. So it's important that you use your weapon carefully, because that's the only weapon that you have. So you don't draw your weapon like, when we were in college, there was a lot of people who used to, back in those days, I don't know what goes on in colleges right now. there used to be these student organizations where there some of these people used to think that, like, so just to gain popularity, they would join these organizations and carry guns and all that. And even the slightest drop of a hat, they would pull out a gun. Now, the problem of pulling out a gun is when you pull out a gun, you have to fire it. See, that's a different ballgame. So, in the similar sort of situation, so whenever you're thinking about putting up Syntocin on, just let's think about it, because that's the only thing you have. So maybe she's not in active phase, yes, which is another thing which we need to discuss, because the active phase has changed, which I've been going around telling people all the time, that the latent phase and the active phase, and what the consensus about that is being formed. In Pakistan, we were brought up with 3 centimeters after that active phase, 4 centimeters after that active phase. Now they're saying that the latent phase lasts till about 6 centimeters. And if you actually give her a chance and don't interfere, she will actually progress, because a lot of the arrest in labor is happening between, if you notice, that failure to progress is being diagnosed not at fully dilated or not at 8 centimeters or 9 centimeters. It's been diagnosed at 4, 5, 6 centimeters. So whenever somebody does that, it could be true, but just think about it. Okay? All right. So bradycardia, hypothermia, temperature, hypoglycemia is something you can think about. Hypothyroid people. This is very important, because, and the last line I've written, I've tried to write when I was half asleep, fetal heart block or interruption of fetal oxygenation. This is the key point. Whenever somebody comes to you and she's contracting, what is happening to her every time she has a contraction is there is a transient, maybe insignificant, maybe the baby is good enough to tolerate it, but there is an interruption of fetal oxygenation every time she's contracting. So if the babies are healthy and they're well taken care of and there's no other issue going on, then it shouldn't affect her. But if there is something going on in the background, what is that thing that I'm referring to? I've told you that multiple times when I come downstairs. IUGR, we've heard of that. What's the thing about IUGR that you think it's an IUGR? Why does the scan person, or when you were scanning, what is the thing on the scan that you?
The growth is 5 days. It's
How?
not corresponding to the days.
How's that? Why the female length isn't?
It's abdominal circumference.
Well done. Good. So what happens to the head abdominal circumference? Guys? Huh? Huh? Abdominal circumference is less than the head circumference by more than 2 weeks or something. Okay? So that's when they start thinking, acha yaar, IUGR maybe, even though the strict definitions of IUGR are completely different. But in practical reality, Desi reality in particular, even abroad, everybody's scared. Nobody wants to lose a baby. Okay? So that's uh, that's the thing. Why is that important? Why is the tummy not growing as much as the head? Ever thought about that? Guys, you can join in if you want, if you're not asleep yet. Okay.
Brain is also the white organ. Blood supply is being
All done. Okay.
The brain's effect.
Fine. Absolutely. The brain sparing effect. So the brain sparing effect is happening. At the same time, what is happening? What's the thing about the abdomen which is so important? The abdomen it's basically on top of the liver in healthy babies, in babies who are TikTok, they have deposits of glycogen. So that glycogen, Alamia has kept that in babies for the time when it comes to labor. So what happens is that when there is interruption of fetal oxygenation, where do you think the baby is getting the energy from at that time? Because remember, in late labor, the contractions can last for almost 50, 60 seconds, it's quite wild there. Okay, so during that time, that glycogen is used for the baby to even shuru se, whenever she starts contracting, that glycogen is utilized anaerobically to produce energy for the baby. So the energy requirements of the baby are met. Okay? So if that deposit of glycogen is not present on the baby when when he's like, or he or she, the baby is like 28 weeks, then what happens is that that baby is termed as an IUGR, okay? Because head is getting bigger because the blood supply is referred there. As soon as she goes into labor, or even sometimes before that, there's no deposit there. There's no compensatory mechanism for the baby to produce energy without oxygen, okay, anaerobic. Okay? And you start getting this. So it's important to know who you're dealing with, be it be an IVF pregnancy, be it be an IUGR baby. If you tell me 36 weeks, she's coming having pain, and she started, having these early dips, I'll say, "Acha, theek hai." So, yeah. But if you tell me that IUGR baby bhi hai, and I'll say, "Acha." So it's like, it's a, always take the whole picture. This is not the be all and end all of anything, this CTG. But if you correlate, you always need to correlate with your patients to find out. Tachycardia, exact opposite of that. Fever, infection, important. That's why I always say that whenever somebody comes in with leaking, the first thing you should do after confirming the leaking, when you're doing a speculum, take an HBS, for God's sake, which we're not doing, which we should do. Okay? And don't do that. Okay? Medications, hyperthyroid, elevate, it's anemia. We'll come to that also. Interrupt, and Akhri wali line is the same. Interruption of fetal oxygenation. That is what happens. That is primarily the reason why things go wrong, or things, you think things are going wrong. Okay, how am I supposed to change this thing now? यहाँ से यूं
Every patient with leaking, either it's happened to hours back or 6 hours back, regardless of that time.
I would always take a base time. Yeah, नहीं ठीक है ठीक है अच्छा हुआ था अच्छा आगे आगे नहीं मैं ओके हाँ ठीक अब हो गया thank you. All right. This is probably the most important thing. This is what people have been ranting about, variability. Fluctuations in baseline that are irregular in amplitude and frequency. Basically, it is the fuzzy line that appears with every beat. It's called beat to beat variability. ठीक है जी? अब ये क्यों हो रहा है? इसको समझ लो थोड़ा सा, ठीक है? Apologies for speaking in our national language. Okay. Sympathetic and parasympathetic branches of the autonomic nervous system. Okay? Just remember, parasympathetic, always have trouble remembering this, so apologies. Parasympathetic means come, sympathetic means zyada. Okay? And now it will start making sense. Up here, what is moderate variability? What were we discussing? What is normal variability? Chalo batao. 6 to 25 got it. Okay? 6 to 25. And now 6 pata chalega, na 5 pata chalega. But still, okay? As with the baseline, as with an acceleration, moderate variability is normal. What does it reflect? At this present time, the baby is having adequate oxygenation of the CNS. Okay? And it also tells us at the same time that there's no evidence of hypoxia. And hypoxia से जो metabolic acidemia होता है, which you check by doing the pHs, that is not happening. So baby is doing well. Any baby that is doing well, any category 1 CTG will basically reassure you with 2 or 3 main things, which is a baseline, which is reasonably normal. a variability which is somewhere between 6 to 25 beats per minute. It goes up and down, not too much, not too less. That and an acceleration every now and then, maybe 1 or 2 in 20, maybe 1 in 10. That's okay with me. Maybe no acceleration but good variability with an absence of decelerations. Even though if there is a deceleration, it's very temporary, it's fleeting, it's not coming back, and it's like even early. We'll discuss that later. What it basically tells you, a category 1 CTG means that the baby is getting enough oxygen. The interruption is not having any effect. The CNS is grossly intact, and there is no hypoxia happening. And acidosis, there's no sawal pada, you know. So this is what a category 1 CTG is supposed to inform you. You are still supposed to repeat a category 1 CTG in half an hour. Nothing in this world is permanent. Don't take it for granted that there's nothing happening. Anything can happen. That's labor. That's the problem. Everybody's gone through. You spend your whole night, you deliver the baby, everything is okay. You go out, you think, thank God, yeah. Sorry, there will be you know, and then you're stuck. So anything can happen. So just make sure that, and you always, whenever you're counseling the woman, never go in advance, never talk about too much in the future. Always say that at this time, your baby is doing perfectly well. We will continue monitoring this pregnancy. We will continue monitoring your labor very closely, and we'll hopefully have a normal delivery. But somewhere along the line, should something happen, I will inform you and I'll let you know, and there might be change of plans. Okay? We're doing the bloods just because we want to be prepared for what lies ahead. God forbid if there's any need. And that's all. Don't counsel them too far ahead. All right. Other conditions where the variability, if it's slightly above normal, is reasonably okay. You can tolerate that sort of nonsense. But it's less than that, then be alerted. I'm not asking you to start jumping around all over the place. But then just bear with it. Because a lot of the times it's normal. Some of the time the baby is sleeping. Okay. Then we come to the absolute, arrhythmias. Then she will continue to have it, and then you'll continue to be surprised. Arrhythmia means the rhythm is missing in the baby, so there's something wrong with the baby's heart or something, which is not, it doesn't have rhythm. Preterm, less than 24 weeks, wala. Not before that. I wouldn't assume that, no, I don't think this is Goro wala thumb. Nobody would do a CTG. Please don't put a CTG on until unless you are reasonably confident that you can save the baby. Okay? So don't put CTGs up at less than 28 weeks in our, Park Sarzamin, because you won't be able to do much. Okay? And that gives the woman a false sense of security. And as a doctor, you're stuck. Would you be comfortable doing a hysterectomy or C-section at 26 weeks? See? So always try to be realistic and do a scan at that age. Anomalies of neurological injury, medications, all that. Yeah. All right. So this is the thing. This is about the variability. If it's absent, that's usually a problem. Okay. Minimal 0 to 5. Okay, you can sit on it, but then you should be prepared. Moderate is the normal one. 6 to 25. Marked is more than 25. Okay. Peak to trough. What does peak mean? Trough. Lowest point? No. Niche. Okay? So measured as peak to trough. Have a good look. You're all doing CTGs. Get used to it. Get used to start looking at them the way you should. Develop a method like you do when you're operating. Everybody develops a little bit of a method and it comes naturally. Why do we develop a method? The reason for developing any sort of method at any given time for any given thing is that you don't miss something. Okay? Start, be boring, spend 5 minutes, start with the name. Make sure you write the blood pressure. Make sure you write something, IVF pregnancy, uh, elderly primary, something which which should alert the other person. PIH, history of something. Agar, if she's on medication, please mention that. Okay? That's important. Okay? Something to let the other person know who's taking over from you, or when it goes in the record, that people should know that this, you know, this doctor was smart enough to know. Then you mention your things, then you check out what lies underneath as far as the contractions are concerned. Take it, and then go through it. Go through it like this. याद रखना, if it's moving too much, there's too much variability or something. Usually it's nothing, but sometimes, I'm that sort of person who's quite anxious with babies. So there's no point being heroic about babies because babies are babies. So कभी कभार होता है कि marked increase हो जाए all of a sudden. And the marked increase, whenever I say an abrupt change, a gradual change, or a marked increase, whenever that such words are used, that means that the baseline was probably different. The previous CTG was probably different. Okay? So even by the baseline standards, any baseline, like which is the baby's going perfectly, baseline 140, 145, and you're reasonably okay with it, and suddenly something happens and starts jumping around all over the place, and it becomes 160 for 30 minutes or so. When would you say that it's a change in baseline? How long before you, rather than calling it a prolonged decel or a prolonged acceleration, when would you actually call it a change in a baseline? Anybody can say anything. There's no judgment here. अगर नहीं पता,
Baseline as in categorization.
हाँ,
So it would be less than 5 or 10 minutes से ज़्यादा हो, that would be a red category. और 25 से ज़्यादा हो तो between 30 to 50 minutes वो amber होगा.
10 minutes. ठीक है? 10 minutes से ज़्यादा का acceleration category में चले जाए. Yeah, apologies again. And going down to the deceleration. If it lasts for more than 10 minutes, that's a change in baseline. Okay? Change in baseline could be last night CTG, this morning CTG, change in baseline, check. When you take over from somebody in the morning, last night CTG, this morning CTG, any remarkable difference? If there is, highlight it and let the other guy decide, or try to ask them questions when your consultants come in and strut around. You just asking, Ajahn, did you get a chance to have a look at the CTG? Why do you think it's important? And find out what he thinks or she thinks. Okay, that's important because this will happen. Labor room.
सर इसकी क्या सिग्निफिकेंस है? मतलब अगर कल वाली सीटीजी में, रात वाली में और सुबह वाली में बेसलाइन चेंज हो गई है, लेकिन है वो नॉर्मल में, एक्सेलरेशन भी है, डिसेलरेशन भी नहीं है, वेरिएबिलिटी भी है, लेकिन बेसलाइन चेंज है, उसकी सिग्निफिकेंस प्लीज बता दे.
Significance is that there is something going on there. Something has changed with the baby. You always, what the whole point of doing a CTG or the whole point of monitoring his labor is not trying to find out new things. You're just trying to be as safe as you possibly can. You must document a change in baseline. It could be nothing or it could be something. There are only two ways to think. Okay. It is important that the only reason why we do CTG is not to monitor the baby to death or something, is to intervene in time. So if the baseline is changing, it could be an early sign that, these things happen when in early stages of hypoxia. Sometimes you get away with it. Sometimes you'll have to intervene at some stage. It's your job as a doctor to be alerted to the fact that when you come in, your junior doctor shows you the CTG, you have a look at it, and you say, okay, fine, continue, but at the same time, get bloods done and just be slightly ready to intervene should we have to. You don't need to even tell the patient that at that stage, because the CTG is reactive and it's a category 1 CTG. But in your mind, you should be aware. This is particularly important. I'm talking about early labor now. But in late labor, when she is contracting and she's like 7, 8 centimeters dilated, and suddenly you start getting these braddies, and then there's a thing called prolonged decel, and then there's this thing which is called prolonged deceleration. Prolonged deceleration by definition means less than 2 minutes. Carries on for 10 minutes. I think it's significant. Assess and see what happens, and you might need to deliver. You know, so that's basically there's only one thing we need to be alerted as far as CTG is concerned. You should know when things are turning a bit south, and the south meaning that things are not going well for the baby. And if you realize that earlier and you're prepared for it, that makes a lot of difference, both to you, your blood pressure, and the patients also. So that's the only thing. I'll explain what I'm trying to tell you. Thoda sa aage, just a minute. Okay. Uh, in accelerations and abrupt. What does abrupt mean? Sudden. Okay. Time length. Anything which happens in less than 30 seconds is abrupt. Remember, anything that happens in more than 30 seconds is gradual. Okay. So an abrupt increase in fetal heart. If she's less than 32 weeks, why less than 32 weeks, more than 32 weeks? What the hell is 32 weeks more important? What happens at 32 weeks? You can join, please.
ऑटोनॉमिक नर्वस सिस्टम में
बिल्कुल ठीक है जी, excellent. Autonomic nervous system gets developed. ठीक है जी, 10 seconds, 10, 15, 15. ठीक है जी, prolonged वही अभी बात जो आप कर रहे हैं. Prolonged acceleration is more than 2 minutes plus than 10. More than 10 minutes is the change in baseline. ठीक है जी, are associated with के छलांगे मारने वाला baby which moves around a lot. Uh, there's a thing called peripheral proprioceptor, by the way. Okay. Uh, which causes an increase in the catecholamine release. But as far as your exam is concerned, this is more than enough as the reason for a thing. Basically, proprioceptors, catecholamine release, and autonomic stimulation of the heart. And usually it's an increase above the baseline. Because obviously, it carries on longer than 10 minutes. Think carefully. Check the girl's temperature. Rule out any sort of infection. And then also remember that early stages of hypoxia, reflexly, we'll come to that. The baby's heart rate goes up. Now we come to our very interesting best friend, deceleration. Unrelated to fetal oxygenation. There are two sorts. Earlies are our friends because earlies are good. But early comes very early is not a great sign. Okay. If you start getting early deceleration that when she's like in latent phase of labor, 2 centimeters, and with an IUGR baby, then earlies also assume quite a lot of importance. Gradual, abrupt say gradual. Gradual is more than 30 seconds ke liye, it's gradually, it will go down. Okay? And return to baseline associated with a uterine contraction. What does that Nadir mean? Nadir Shah attacked Delhi also. So it's not Nadir, it's Nadir. Okay. Nadir is the top of the fetal heart. Like it goes up. The topmost thing is 160 or touches 168 or whatever. and the peak of contraction occur at the same time, usually. Okay? क्यों हो रहा है? Maybe due to compression of fetal head during the contraction. They're not sure. If they're not sure, then why the hell should we bother? So somebody asks you why that's happening, you just say compression of the head. What is important is the last line. वही वाली बात है, interruption of oxygen that's not taking place. अब academia नहीं है बेटे, academia है, ठीक है? ये I was sleeping, okay? And or hypoxic ischemic neurological injury. This is not associated with anything bad, and that's the most important thing. No interruption. Interruption होगी, acidemia होगा, injury होगी. Injury then जो होगी is not predictable. Maybe you'll be able to revive the baby from a cardiovascular point of view, but God forbid, if something's gone wrong neurologically. Have I told you about the guy in America, a gynecologist, quite a decent gynecologist, happened way back. This changed the whole scenario of medical legal cases in the world. It happened, I think, in the 1970s, 80s, something before our time. But whenever it happened, it happened. So this very famous gynecologist had delivered a baby by forceps 21 years ago. That boy sued the gynecologist at the age of 21, of course, okay, and told him that I can't get into a good college because I am mentally slow, because my mother was contracting this long and he left me inside and didn't apply the forceps sooner, or maybe got a technique wrong with the forceps or something, and I got birth asphyxia. As a result, I'm mentally slower than other people. And he won and got about $4 to $5 million or something, quite a lot of money at that time. That completely changed the whole concept of practice, particularly obs and gynae. If you happen to go to America, there are floors there like this hospital, and in the reception area, you will invariably see, or in the cafeteria, you will invariably see a few people with suits and ties sitting there with laptops. They're not doctors, they're lawyers. They're literally handing out leaflets to the patients who are leaving of, of all departments and everything. Did anything go wrong? Did you feel? In the UK, if you've gone there, you will notice that you turn on the TV, there are ads there of lawyers every now and then who claim that we will represent you free of charge. We will fight the case for you against the medical doctor or NHS or somebody. And then you can, once we get paid, then we'll take a percentage then. But before that, you don't have to do anything. So that's why people are scared. That's why people, there obviously everybody is still working. That doesn't change anything. But that's why when you go there, we go there as a minority, as a foreigner, we need to be extra careful. You need to, that's why I stress on the fact that you need to start talking to people. If you are planning to go there, start talking to your patients. Start talking to them. Don't promise them the world. Talk to them very nicely, politely, be friends with them, whatever, but never, always stay in the moment. Always add that little line, at this present time, everything is going well. At this present time. That's why CTG, that's why I'm trying to make you understand what things you are under your control, and there's still certain things which are in Alamia's hand. So, so that just to be careful. All right, we come to the bad part. All right. Decelerations जहाँ पे there is actual interruption. हो गया time? 5 minutes रह गए. ये जल्दी से पढ़ लो. All right. There's a gradual decrease more than 30 seconds. ठीक है जी? Onset, nadir is the top. and recovery usually occur after the onset, peak, and termination of a contraction. Everybody knows that. पता है late decel है. All right. हो क्या रहा है? There is a uterine contraction. Uterus के अंदर क्या है? Maternal blood vessels हैं. Maternal blood vessels get compressed. क्या हुआ है? The fetal oxygen which is carried in the fetal blood capillaries वो नीचे हो जाता है. CO2 oxygen की decline करती है. क्या हुआ? Contraction, compression of blood vessels, reduction in oxygen in the blood, fetal blood capillaries. ठीक है? Decline in oxygen levels in the blood. और ज्यादातर एक होता है कि there is this contraction which is more than 35 amplitude contraction. That is, there was a time when we used to measure the amplitude of the contractions also, but that is quite significant. And when those start happening, which are the proper contractions, happen later on when she's trying to push also, and that is the time when this can happen a lot. So you need to be very careful. That's why people lose their sleep, people lose their hair, and people have white hair and all that. You know? So, so it falls below 15 to 25. Chemoreceptors, you understand? You know what these chemoreceptors are? They're not chemo receptors, but they are chemoreceptors. Okay? They initiate not autonomic reflex. What did I tell you about the sympathetic system and the parasympathetic system? Sympathetic system will increase the blood pressure. Parasympathetic will decrease the blood pressure. Sympathetic flow, vasoconstriction, shifts blood away from non-vital regions to brain, heart. जो कि कहाँ होता है? अपनी क्या बात हो रही थी? IUGR में, हाँ, ब्रेन स्पेयरिंग इफेक्ट, ठीक है? दिमाग जरूरी होता है, अल्लाह में भी ये कहता है, लेकिन हमारे मुल्क में नहीं है, ठीक है? तो दिमाग नहीं, हम दिमाग, हाँ, तो increase in blood pressure. This is detected by baroreceptors. Are friends again? Baroreceptors basically they pressure को पकड़ते हैं. Parasympathetic triggered, heart rate slowed, decreased. क्यों? वो dilatation करता है. The exact opposite of what was going on. Allah Mian has built a system where there is balance. If there is no balance in the baby, and the baby becomes a child, the child becomes a young man, the young man becomes a middle-aged man, the middle-aged becomes an old man. There has to be balance in life. Parasympathetic ANS is triggered. ANS reflex response, sympathetic increase in blood pressure. जब ये होगा, the heart rate will initially go up. Response होगी, the heart rate will then go down. Okay? That means you're in trouble. Sometimes it works well, but sometimes what happens is it's interrupted sufficiently to sustain severe hypoxia, which cannot be controlled. In most pregnancies, this is happening. But we're lucky, and Alamia looks after the baby and everything, and things go well. But जहाँ नहीं होता, will we talk about later before he kills. All right, okay, बंद कर दो. अब पूछो कुछ. पूछना इससे रटा हुआ, so that तुम्हें पता होगा क्या हो. इसीलिए when the fetal heart rate goes up initially, तब वो शुरू में क्या होता है, में चेंजेस आते हैं, शुरू में ये हो जाता है, जन्म में नहीं होता, काम पढ़ते तो नहीं आया, लेकिन ये जरूर याद है. और शायद आपकी उसके बच्चे की बेसलाइन ही कम नॉर्मल हो, लेकिन 120 हो, और वो जब उसको 120 से 45 से जब है, तो इसका मतलब है कि वो अपना वो उस वक्त